Okay. So good morning, one and all. On behalf of our institute, I would like to welcome one and all for the Coagulation Workshop Lecture Series on the occasion of World Hemophilia Day. Our department, ICMR NIIH, in association with Hemophilia Society Bhubaneswar chapter, have organized a coagulation workshop from 18th to 22nd April 2022, wherein we have eminent lecturers delivering lectures on different aspects of coagulation, and we have the hands-on practicals for the participants sponsored by Hemophilia Society Bhubaneswar. I request Dr. Bipin Kulkarni, Scientist D and the chairperson of this event, to welcome all.
Good morning again. So as Dr. Rucha said, so in line with the World Hemophilia Day, which falls on the 17th of April, we have organized this workshop to commemorate the World Hemophilia Day. So on behalf of the staff and students of the ICMR NIIH, I welcome you all to the workshop on hemostasis. We have two components in this workshop: the lecture series, which will be on a virtual platform and are open to all those who are interested in hemostasis. The second component is the hands-on wet lab training in hemostatic diagnostic techniques, which is limited to pathologists and their lab technicians who are affiliated to a public funded institute or a hospital laboratory. We have total 4 trainees for the hands-on workshop, and I welcome you all. And we have 300 participants who have registered online for the lectures, which will be delivered by the best of the best laboratory scientists and physicians in the field of hemostasis. We have 5 distinguished invited faculty for the lectures: Professor Jasmina Aluwalia, who is Professor, Department of Hematology, PGI Chandigarh; Dr. Prantar Chakrabarti, who is the Director, Hematology and BMT, AMRI Hospital, Kolkata; Dr. Sukesh Nair, Professor, Department of Hematology, CMC Vellore; Dr. Srimati Shetty, who is the Director now of Laboratory Hematology and Clinical Research Unit, KJ Somaiya and Medical College and Research Center, and she is the ex-Senior Deputy Director of ICMR NIIH Mumbai. And we have Dr. Chandrakala, who is Professor and Head of the Department of Hematology, KEM Hospital, Mumbai. We are extremely thankful to them for having agreed to share their valuable knowledge and time for this workshop. We have tried to cover all the major areas of concern in the area of laboratory hemostasis, which are crucial right from the basic diagnosis of a bleeding patient to the subsequent follow-up investigations that are required for proper management of the patient. This applies for both the components of the workshop, the lectures, as well as the hands-on wet lab training. We are extremely thankful to our director, Dr. Manisha Madkaikar, for her wholeheartedly supporting us to organize this workshop and to conduct this workshop at the NIIH. I once again welcome all the participants, both online and offline, and I am fortunate to have a great team of very capable scientists and colleagues here at the Department of Hemostasis at the NIIH, and I am sure together we will make this workshop successful. I now call upon our director, Dr. Manisha, to formally inaugurate and give her address.
All the participants who have come from different parts, then all the scientists of our institute, all the participants who are joining online this workshop, and my colleagues who are sitting here. So on behalf of ICMR NIIH, again, a warm welcome to all of you. Today, on the occasion of World Hemophilia Day, we decided to hold this coagulation workshop along with the lecture series, which is, so it's a hybrid mode event, which will have online lectures and hands-on for those participants who are here. So coagulation system is a very delicate system, intricate system, and critically balanced. So is the assessment of coagulation system. It is very important. There are many practical points that one has to remember when you are assessing a coagulation system and interpreting it. And it comes with only with great experience of many years. So our institute actually has a department of thrombosis and hemostasis, which is, I think, more than 30 years old, established by our previous director, Dr. Mohanty. Then Dr. Ghosh and Dr. Srimati Shetty has taken this department to a great height. And now we have young scientists, Dr. Bipin and Rucha, who are carrying this responsibility forward. So this department actually has contributed in a great deal, or this institute has contributed in various ways in the field of hemophilia, and done extensive surveys, established the first prenatal diagnosis for hemophilia, molecular characterization of various bleeding disorders, having cohorts of different bleeding disorders, and we have learned a lot from evaluating all of these. And it is always important that this knowledge is shared with all of you. It is so all of you are benefited by the experiences of the department. And this is basically planned in the form of lectures and followed by hands-on technical sessions. We would have definitely loved to have more hands-on people. However, because currently actually the institute is undergoing renovation, we have a space crunch. So that is why only 4 people are currently doing hands-on. I hope that every year this practice is continued and we have more and more people taking hands-on training, because that is something probably is more important. Just giving one lecture, it is very difficult to actually apply what you have learned. So with this, I think we have to train you, as Bipin has said, great faculties from all over India and from within the institute. So I'm sure you will have an enriching experience in next 3 days, and you will learn a lot. It is the learning is just beginning. This workshop, let it be just a beginning. These people will continue to handhold whenever you need, whenever you have any difficulties, and will ensure that whatever that you have learned is established back home. So I think with these words, I welcome you once again and wish you all the best. Thank you.
Thank you, ma'am, and thank you, Bipin. As Bipin said, I would just like to say that yes, there are 300 participants who have registered, which out of which 60% showed a work experience in coagulation, and 95% were interested in getting a hands-on training in the future. So this is a very welcoming, the registration form which we made gave us good hope that we can continue doing this, and we will definitely aim towards this. Now we will break for a short time and resume sharp at 11 o'clock with the first lecture, which is on overview of hemostasis by Dr. Bipin Kulkarni. Thank you.
Good morning, everyone. Good morning, everyone. So with this first lecture, we begin the lecture series of this workshop on hemostasis, the online sessions. I will be giving the first talk on overview of hemostasis, that is the basics of hemostasis, and then the subsequent lectures will be given by other speakers. I can stop my video. All right. So let's begin. Next slide. Yeah. So to begin with, what does hemostasis mean? Heme is blood and stasis is to halt. That is localized stopping of blood. That is hemostasis. That's the definition of hemostasis. Now it's the process of forming blood clot at the site of injury or at the site where the blood vessel is damaged. Now traditionally it is divided into two components. That is the primary hemostasis, which is because of the formed elements of blood, that is the platelets, and the secondary hemostasis, which is primarily the fibrin clot formation, which takes place subsequent to primary hemostasis. And the secondary hemostasis involves all the clotting factors. Now, before we go on to see what happens in hemostasis, let us first understand what happens under normal physiological conditions in a blood flow. Now, this is a cross section of a blood vessel, which shows the endothelial layer, the subendothelial collagen, then the fibroblast and the smooth muscle cells. Here. Now, under normal physiological conditions, the endothelial cells, they secrete nitric oxide and the prostacyclin, PGI2, which keep the platelets inactive and the blood vessel in a relaxed state. It does not allow the blood vessel to contract, and the platelets are kept under inactive state. So that's how the blood flows while under normal physiological conditions. Apart from that, the endothelial cells also secrete something called heparin sulfate, which is a glycosaminoglycan that binds to antithrombin, and after binding to antithrombin, the antithrombin inhibits the clotting factors factor 2, factor 9, and factor 10. Then there is also tissue factor pathway inhibitor, TFPI, which inhibits factor 7 and factor 10. So under physiological conditions, the blood is flowing without formation of any clots. Now, the one I have shown below in red, because that happens in a feedback mechanism. When there is thrombin in circulation and enough clot is formed, it combines with thrombomodulin, which activates protein C that degrades factor 5 and factor 8, but that happens afterwards. What are the major components in hemostasis? First is you have a blood vessel which is damaged. Because of that, you have exposure of the subendothelial collagen, release of tissue factor. Then the subsequent events happen, that is vasoconstriction, platelet activation. After platelet activation, the primary hemostasis, that is the primary platelet plug formation. Then followed by the secondary hemostasis, that is the coagulation cascade kicks in, formation of thrombin, and then thrombin induces the formation of fibrin from fibrinogen, leading to the consolidated blood clot. Then the feedback mechanism comes into action, that is the natural antithrombotic control mechanisms. Then the last one is the dissolution of the clot or fibrinolysis mediated by plasmin. So now let us see all the steps one by one. First is the vascular spasm. Second is formation of platelet plug, that is primary hemostasis. Third is formation of fibrin clot, that is the secondary hemostasis. Fourth is clot retraction and cell repair. And the last one is fibrinolysis. So what happens when there is an injury? So endothelial cells, they secrete endothelin and the prostaglandin, which causes the smooth muscles to contract. So that is vasoconstriction. Now, because of this vasoconstriction, it restricts the amount of blood that is flowing through the blood vessel. And the second mechanism is also, it's a myogenic response. That is the muscles, they contract on their own when there is a direct injury, rupturing the blood vessel. The smooth muscles go into spasm and the vasoconstriction takes place. The second step is the primary hemostasis, that is the formation of the platelet plug, which happens within seconds to a minute. Now, what are the major steps here? That is the platelet adherence, platelet secretion, and finally the platelet aggregation. The aggregates are formed. Now we'll see what exactly happens. So on top is what I showed in the first slide. Under normal physiological conditions, the blood is flowing. But when there is an injury, what happens? Now this is a place where the blood vessel is ruptured. The subendothelial collagen, the endothelial layer is damaged, the subendothelial collagen is exposed. Then what happens? The von Willebrand factor, the green peaks what you are seeing, is the von Willebrand factor which adheres to the exposed subendothelial collagen, shown here in the red. So once that happens, the platelets, they adhere to the von Willebrand factor through the glycoprotein receptors GP1B95 complex. So on the surface of the platelets, there are several glycoprotein receptors. These are transmembrane receptors which require activation. They are not activated while in circulation, they require activation. And they have specific roles and they have specific ligands. So here the GP1B9, the GP1B95 complex, it binds to the von Willebrand factor. So once the platelets adhere to the von Willebrand factor, it releases the thromboxane, ADP, serotonin, calcium. Because of that, it activates the other platelets in the microenvironment. Also, the ADP and thromboxane together also help in further vasoconstriction. So the whole system becomes, the microenvironment becomes prothrombotic because of the release of the thromboxane A2, ADP, serotonin, calcium. And they activate the other platelets in the microenvironment. Now then what happens? There are GP2B3A receptors as well on the platelets. The ligand of GP2B3A is fibrinogen. So fibrinogen binds to the GP2B3A. And because the other platelets in the microenvironment are activated now, they cross-link with this fibrinogen with their GP2B3A receptors, and it brings about what is called as platelet aggregation in this area. Now this bubble here is called the primary hemostatic plug. Now this plug is formed. What is the next step here? So once the primary hemostatic plug is formed, it gives a surface for the secondary hemostasis to take place. That is the consolidated clot which comes over it. Now let's go to the secondary hemostasis. Now before we go to that, let's see all the factors that are involved. There are 13 clotting factors. They have their Roman numerals as well as their names. Some of them are called by their Roman numerals and some of them are called by their names. So you can go through this list. Not all the factors are called by numbers and not all the factors are called by their names. Now we'll come to the secondary hemostasis. Sure. So let's go to the secondary hemostasis. We were here. Now we had the primary platelet plug. Now on the surface of the platelets, the phosphatidylserines, they are secreted, which are negatively charged. Now the negatively charged surface is what is required for the contact factors to activate. Because of the primary platelet plug formation and the release of phosphatidylserines on the platelet plug, the contact factors are activated, namely the high molecular weight kininogen, prekallikrein, Fletcher factor, factor 12. They are activated. Now, because this is the waterfall cascade, these clotting factors, they are also in their inactive state while in circulation, and they need to be activated by their precursor or the previous factor. Now, once these contact factors activate, factor 12 becomes factor 12A, that is the activated form, which activates the subsequent factor, that is factor 11 to 11A, followed by factor 11 activates factor 9 to 9A. Now mediated by here platelet factor 3 and calcium along with factor 8 and von Willebrand factor as their cofactors. This 9A mediates the conversion of factor 10 to 10A, activated factor 10A. Now again, mediated by the platelet factor 3 and calcium and by factor 5 here, the factor 10A converts prothrombin to thrombin. And this thrombin, that is 2A, converts factor 1, that is fibrinogen, to 1A, that is fibrin clot. Let's come down here. This is the factor 2 prothrombin, which converts to thrombin. Now here, thrombin has multiple roles to play, both in formation of the clot as well as in the feedback loop. Now this thrombin, that is activated factor 2, it breaks down or it converts fibrinogen to fibrin clot. This also has another job, that is with calcium, it also activates factor 13 and it forms factor 13A, that is activated factor 13. Now if you see here, the fibrin clot is formed here, but this fibrin clot is not stable enough. The fibrin stabilizing factor, that is factor 13A, is required to stabilize this fibrin clot. A factor 13 or 13A, activated factor 13, will cross-link the fibrin strands to strengthen the fibrin clot, and this becomes the consolidated clot. Now if you see here, there is factor 7, which is activated by tissue factor. Now this cascade, the intrinsic cascade, this cascade here on top here is called the intrinsic pathway of coagulation. Whereas this one, what you see here, is called the extrinsic pathway of coagulation. Now for the convenience of laboratory testing, the coagulation cascade was divided into the intrinsic and the extrinsic. Whereas in physiology, there is no clear distinction. Now this pathway is activated by the negatively charged surfaces, whereas when there is a tissue injury, the tissue factors are released by the fibroblast directly, which activate factor 7. Now this factor 7 converts to factor 7A, activated factor 7, which activates factor 10 to 10A, and this 7 also acts on factor 9 to convert 9 to 9A. So this has dual role, that is to convert 10 to 10A and 9 to 9A. And from here, the cascade begins here again. Now I have circled some of the factors in yellow highlights, and vitamin K plays a major role here in the maturation of these factors. Factor 7, 9, 10, 2, and 2 other factors in the natural anticoagulant system, that is protein C and protein S. They require vitamin K for their maturation. With the help of gamma glutamyl carboxylase, the gamma carboxylation is required for these factors to mature. So when in newborns, where the vitamin K, which is a dietary vitamin, is maybe deficient, you can have a deficiency of the vitamin K dependent factors, or in case of liver disease, because these factors are produced and matured in the liver. So if there is a liver disease, you could have a deficiency of the vitamin K dependent factors. So this consolidates, it becomes the secondary hemostatic plug. So when you have just the PT prolonged, the assays will be, the lecture on assays will be tomorrow or after this lecture in the afternoon session by Dr. Rucha. So she will talk about the assays. But just to highlight, when the APDT is deranged, you can say that one of these factors in the intrinsic pathway and the common pathway could be deficient. When the PT alone is deranged, in the absence of any liver disease, you can say that, it could be because of factor 7 deficiency. Now, if you see here, right from factor 10, it converges kind of. So you have this pathway is called the common pathway because they lie, these factors, factor 10, 5, 2, 1, they lie in the common region of the intrinsic and the extrinsic. So these proteins or these factors, they are in the common pathway. So if there is a prolongation of both PT and APDT, you can suspect the deficiency of one of these factors in the common pathway. The assays part, when Dr. Rucha tells in her lecture, this is the background for that. So you can remember when PT is deranged, what to expect, and when APDT is deranged, what to expect. Now, that was the waterfall cascade. That is, if you imagine a bicycle stand, you need the subsequent factor to be activated by the previous activated factor. And it goes on. So if you take out one factor from in between, the final clot formation is affected, right? So it's like a bicycle stand. If you take out one bicycle, the stand, it will stop collapsing. But this has some inadequacies. Now, what were those inadequacies? Is the activation of factor 10 by the extrinsic pathway, that is factor 7A and tissue factor pathway, does not compensate for the lack of factor 8 or factor 9 in hemophiliacs. Now, if you go back and see, here the factor 7 is activated and it can directly trigger the conversion of 10 to 10A and we can still get the fibrin clot. Then in that case, why do hemophiliacs bleed? Because the factor 9 is here, 8 is here, which is before this pathway. So why should hemophiliacs bleed? That was not adequately explained by this waterfall cascade. And also the deficiency of the contact factors, factor 12, does not cause bleeding. So if there is factor 12 deficiency, it starts right in the beginning. So if there is a deficiency there should be, the pathway should not proceed and the patient should bleed. But on the contrary, in the absence of factor 12, the patient does not bleed at all. Only the APDT is deranged, but the patient does not bleed. So to address this or these inadequacies, the cell-based model of hemostasis, or what we call as the physiological model of hemostasis, was introduced very recently, and it emphasizes the importance of specific cellular receptors for the clotting proteins, and it proposes that coagulation occurs in 3 overlapping stages. So the first stage is the initiation, which occurs on tissue factor bearing cells, the fibroblasts. The second is amplification of the clot formation, in which platelets and cofactors are activated to set the stage for a larger thrombin generation. And the last stage is the propagation, where you get a burst of thrombin, which converts the fibrinogen to fibrin, and you get the overall clot. Let's see here. Now, this is a pictorial presentation here. Now you have the tissue factor bearing cells here, and then you have the tissue factor 7 complex, that is the extrinsic tenase complex. You have the extrinsic tenase and the intrinsic tenase. So the extrinsic tenase, which activates the tissue factor, activation of factor 7 and other factors takes place, that is the initiation. That results into small amounts of thrombin here, which activates, this is a priming amount of thrombin, you can say, which activates the platelets. Now the platelets bind to factor 5, factor 8 and factor 9A at their surface. That is the amplification stage. So here the intrinsic factor, now here what is formed? Factor 9 is also formed. So it activates factor 8 plus von Willebrand factor, the priming amounts of thrombin, that is the factor 2A, which is formed here. It also activates the platelet factor 5 to 5A. Factor 11 is activated to 11A, which converts the 9 to 9A. Now this 9A is also involved. It combines with factor 8, this 9A and 8A, and it also activates factor 10. So this is the intrinsic tenase that is activated here in the amplification stage. Now if you see here, the tissue factor 7, what we saw in the earlier cascade also, it activates factor 9 to 9A. Now with this, the propagation stage takes place. Now you have all the factors which are kind of activated, and then comes the propagation stage where you get large amounts of thrombin, that is factor 2 here, converted to 2A, mediated by here the 10A. Okay, and 5A. So you get a large amount of thrombin, which converts the fibrinogen to fibrin. And then the factor 13 comes into play. Now this is the same pathway divided into color codes. So you have the initiation, which involves the vessel wall, endothelial cells, subendothelial components. The vascular injury, collagen, vasoconstrictions take place. This is the initiation. Then the localization, which involves the platelet and the circulating cellular elements. Then the propagation stage, where you have tissue factor, the clotting cascade, thrombin, and the clot formation here. The blood clot is formed. Then the termination stage, that is, natural anticoagulants are involved here, protein C, protein S, and the feedback mechanism, where you get no more clot formation. And then the elimination, that is where the fibrinolytic cascade kicks in and you get degradation of the clot. The next stage is clot retraction and repair. Now you have the primary hemostasis, vasoconstriction happened, primary hemostasis happened, secondary hemostasis happened. Now you have the clot retraction and repair. Now the clot is formed. So when you do the clot retraction, when you keep the blood samples after an hour, you get the clot which is retracted in a normal sample. So that is because of the contractile proteins in the platelet, that is actin and myosin. Now platelets, because of this, the clot which is formed, it is kind of strengthened or it kind of retracts and it brings closer the damaged tissues. Now the platelets secrete something called the platelet derived growth factors, PDGF. Now this platelet derived growth factors, it triggers the proliferation of smooth muscles. The smooth muscles that are injured, it repairs the smooth muscles and the collagen tissue which is damaged during the injury. The platelets also secrete something called as vascular endothelial growth factors, VEGF. Now, as the name suggests, it is the endothelial growth factor. It regenerates or helps in regenerating the endothelial cell lining which is damaged. So in this mechanism, the clot that is formed, it retracts. The contractile proteins act there. Then you have the PDGF and the VEGF, which help in the damage, the healing of the damaged tissue. And then the last one is the fibrinolysis, or the clot that is formed after healing. You don't require the clot anymore, and that fibrinolysis has to kick in. Now the endothelial cells, they secrete something called plasminogen activator, tissue plasminogen activator, TPA. Now, as the name suggests, plasminogen activator, it activates plasminogen, which reacts with TPA to form the active protein, that is plasmin, which degrades the fibrin clot and forms breakdown products, which are called D-dimers, which are absorbed back in circulation. Now here also, this pathway is a highly regulated pathway. It has its activators and inhibitors. Now, any imbalance in any of these pathways, right from the beginning, primary hemostasis, secondary hemostasis, slowing down of the clot formation and the breakdown of the clot, it all is balanced in a very delicate way. If the balance tilts, either ways, you can either have excessive bleeding or excessive clotting. Now, let's quickly go on to what are the 4 steps in complete hemostatic investigations. Like we saw now what is hemostasis, the basics of it. When you can come to the investigations, the most important thing is complete history of the patient. History, then physical examination, then followed by complete blood count, peripheral smear, and then the screening coagulation test. The screening actually, before you come to the actual screening coagulation test, The most important thing is a complete history. To assess whether the patient has started bleeding now, depending on if it is a child or if it's an adult patient, what is the history, whether it is a mucosal bleed, whether it is a deep muscle bleed, whether there is family history. All these are very important before coming to doing any of the tests. Then comes the special test to define the precise nature of the defect. That comes at the very end, deciding what investigations to do. Now, clinically, what questions should be asked, relevant questions is the bleeding significant? Now, many times what happens, like we get referral cases where the clinicians say that the patient is bleeding, but the APDT is like, if your normal is 28, 29, the APDT is around 33, and they call it as a deranged APDT, and we end up doing all the investigations because the clinician says that the patient has a bleeding. But whether the bleeding is really significant, or a normal individual will also bleed similarly if they get that kind of a trauma. So that assessment has to be done, whether the bleeding is local or systemic. Platelets versus coagulation disorder. If it is a mucosal bleed or a deep muscle bleed, that will tell you whether it is a platelet bleed or like, for example, if you want to distinguish between a hemophilia and a von Willebrand disease. So whether it's only superficial bleed, mucosal bleeds, or if there is any deep muscle bleeds as well. Now, to distinguish between inherited and acquired, the family history, whether the bleeding is from the childhood or now it has, as an adult, the patient has started to bleed after a certain episode or, suddenly. So all that has to be assessed before you start doing any investigations or refer for doing any investigations. Then the type of bleeding, whether it is superficial hematorosis that we spoke about. Also important is the transfusion history. Now, many times what happens, a bleeding patient is given some transfusion, some plasma is given and then sent for investigations. Now, if the laboratory is unaware that the patient has received some transfusion, we will do the investigations, mostly it will be normal, and then there will be no remark on it whether the patient is transfused, whether this was a post-transfused sample or whether it was a baseline sample. And then sometime later, the patient will get the investigation done somewhere else, which is a baseline investigation, and then the earlier lab will be questioned, how did you get the normal values? So the laboratory has to be well informed whether the sample that we are sending or whether the patient that we are sending is the baseline or whether we have transfused the patient with anything. And that has to come on the report. Paternal consanguinity, that will give you an idea whether you're looking at an autosomal recessive kind of a disorder, if it is an inherited disorder that you're looking at. Family pedigree is very important, whether only males are important bleeders or both sexes. Particularly when you are have to distinguish between a hemophilia and a von Willebrand disease, for example, then this history is very, very important to ask whether only the males are bleeding or there are females in the family that are also having some bleeding disorder. Now, the response to treatment, if you are suspecting an inhibitor, how is the response to treatment? Whether the patient is responding well or you are suspecting any inhibitor. Now, age of presentation, as I said earlier, whether it's a small child presenting with a bleeding or an adult where you can suspect an acquired deficiency or acquired disorder, or if it's a child, it could be a congenital. What could be the disorders now? It could be anywhere in the platelets, coagulation proteins, or the combined platelet and clotting proteins, or the vascular disorders of the vascular integrity, or prothrombotic disorders. Now, starting with thrombocytopenia, like any sample that comes, you have to do a CBC, platelet count, and a smear. You have to look into the morphology as well as you have the fresh sample with you. The platelet disorders, it could be also, if it's a small fetal sample, then you have to suspect neonatal albumin thrombocytopenia. If you are suspecting, that has to be ruled out by doing the human platelet specific antigen genotyping, which we do. Or the impaired platelet function. It could be because of non-steroidal this decreased platelet adhesiveness associated with therapy or von Willebrand disease or congenital platelet function defects. That has to be ruled out. The clotting factor deficiencies, it could be X-linked recessive, that is hemophilia A or hemophilia B. Autosomal recessive disorders, which involves all the other clotting factors except for other than hemophilia. Here I have highlighted factor 12 because factor 12 deficiency does not cause bleeding. As we saw in the cell-based model, the factor 12 did not have a major role there. So that is the reason factor 12 deficiency patients do not have any bleeding manifestations. Von Willebrand disease, acquired deficiencies could be vitamin K deficiency. So if it's a small neonate or a patient with a liver disease, so you have to first see before doing any coagulation studies or asking for any factor assays, you have to rule out if there is any underlying liver disease, because otherwise all the clotting, all the vitamin K dependent factors will be on the lower side, which will not help you. If it's a DIC, then it's a combined platelet and coagulation bleeding. It is secondary to any inappropriate, systemic activation of the normal clotting mechanisms. Hepatic dysfunction, I just spoke about. And otherwise, it could be disorders of vascular integrity. You can get everything normal there, like you do a platelet count, platelet morphology, the platelet function, the screening coagulation factors, everything could be normal. In that case, if the patient still has bleeding, you have to rule out if there are any disorders of vascular integrity, like the hemorrhagic telangiectasia and other disorders. And then, of course, if there is thrombotic complications, you have to rule out the deficiencies of any natural anticoagulants there. And you can get artifactual prolongation of APDT under certain conditions. PT we saw, PT prolongation you can get with certain drugs if the patient is on warfarin or if there is a liver disease, if there is vitamin K deficiency. APDT prolongation also you can get if the CRP is high, which is an acute phase protein, and it has affinity for phospholipids, and it interferes in the APDT assay. It binds to phospholipids and falsely prolong APDT. Also, if there is lupus anticoagulant, it's antiphospholipid antibody, it can falsely prolong your APDT, and it could be transient. So you have to have different kinds of APDT reagents that I will also speak about. Now, normal APDT does not always mean a normal hemostasis. Now, this table shows different clotting factors, their reference values, and at what level you can get normalization of APDT or near normal APDT. And if you look at these factors, like a factor 2, 15%, factor 5, 40, factor 8, 35%, 20%, 25, 30, 20%. At these levels, you can get a near normal APDT. But if you suspect a clinical bleed, like bleeding diathesis, don't just go by APDT. If you suspect a bleeding, you have to still go ahead and do the factor assay where you can get some mild moderate deficiencies. So clinical judgment is very important, like not just the numbers or the values of APDT. Now, what to consider before doing factor assays? If there is bleeding, pre-surgical, therapy monitoring, labeling of factor VIII concentrates, checking factor levels in FFP, this we do regularly for blood banks. As a thrombophilia marker also, if you are suspecting very high levels of factors, that could be in under such conditions also you can ask for a factor level, or other acquired causes where you suspect the deficiency because of acquired disease. And what are the laboratory investigations for doing factor assays? If you get a deranged PT or APDT or TT, or as I showed earlier, if you get normal PT, APDT, TT in the presence of a positive bleeding history, the reason the earlier table. Now I spoke about the APDT reagents. Now every laboratory ideally should have both types of reagents, which is high phospholipid containing reagent and low phospholipid containing reagent. So if you are suspecting like a bleeding disorder, then you should always use a high phospholipid containing reagent, because the prolongation of APDT because of any transient antiphospholipid antibody will be neutralized there, and you will get a prolongation of APDT only if there is a genuine deficiency of any of the factors. Otherwise, if there is a transient lupus anticoagulant, antiphospholipid antibody, and if you are using an APDT reagent, which is lupus sensitive, meaning having low phospholipid content, you will get falsely prolonged APDT, not associated with bleeding, but associated with lupus anticoagulant. So if you are suspecting, or if you want to diagnose a bleeding disorder, you should always use phospholipid reagents which are insensitive to lupus anticoagulant, that is high phospholipid containing. Now, some reagents are insensitive to contact factors. Now, recently, there are some good papers which also talk about what reagents to use in case you are using extended half-life factors for factor 8 and factor 9. So the APDT reagent contain different kinds of activators. So some have silica, some have ellagic acid. Now, if the patient is now the factors are constantly evolving. Now with the extended half-life factors, not all the APDT reagents work efficiently. Some end up under-reporting the factor levels, whereas the others end up over-reporting the factor levels. So you have to be very conscious about what factors the patient is taking, whether it is extended half-life, and depending on that, what kind of APDT reagent you should be using. Particularly the activators is very crucial. So you have to be very aware of this before you pick up a APDT reagent for doing factor assays. Now these are the laboratory investigations put in a tabular form. If you get a prolongation of the screening coagulations, what factor deficiency might be involved, what are the genes that are involved for the deficiency of those factors, and what could be the acquired causes of the prolongation. If you get a PT prolongation, it could be factor 7 deficiency, where the factor 7 gene could be mutated or defective. Or if you have to look at the acquired causes, it could be oral anticoagulants, liver disease, sepsis, DIC, etc. APDT prolongation, of course, all the factors in the intrinsic pathway, it could be any of the factors which are deficient. Or the acquired reasons could be oral anticoagulants, same liver disease, sepsis. Thrombin time, which denotes the conversion rate of fibrinogen to fibrin. If there is deficiency of fibrinogen, you get a prolongation of thrombin time. Again, in liver disease, sepsis, you can get, these could be the acquired causes. If you get a combined deficiency of PT, APDT, it could be because of some of the factors in the common factor pathway, which could be deficient, or it could be again because of liver disease. If all three of them are PT, APDT, and thrombin time, if they are deranged, it could be because of factor 2 deficiency or afibrinogenemia, fibrinogen deficiency, or again because of liver disease, sepsis, DIC, or even it could be wrong anticoagulation, that anticoagulant in which the blood is collected. So all these things have to be kept in mind. Now, I'll just briefly touch upon hemostasis in neonates, because that is something which is not comparable to adults. Now, in neonates, the concentration of many hemostatic proteins depend on the gestational and the postnatal age of the infant. So all these values, what we get, PT, APDT, TT factor levels, they are not directly comparable to the adult values. And some of the investigations, they should not be asked in the infancy stages. So that has to be always remembered. So at birth, the concentrations of vitamin K dependent factors and the contact factors are reduced to about 50% of normal adult values. So that the normal ranges has to be established by every lab, or you can refer to the published papers or published literature. The best thing is to do is to have your own established normal ranges, because published papers might have used some other reagents. The APDT reagent might be different, So, and you might be using some different reagents. So you have to establish your own laboratory reference ranges. Now, if the fetus is preterm, the values are further reduced. And but these are normally balanced by parallel decrease in the anticoagulant and fibrinolytic activity. So overall, as a consequence, both thrombin generation and thrombin inhibition are reduced, and these neonates are relatively hypofibrinolytic in nature. They are in hypofibrinolytic state. Now these proteins, they mature by about 6 months of age. So we get very regular requests for very young neonates, infants. We want to do platelet function, or we want to do protein C, protein S. Now these, both the platelet function as well as protein C, protein S should not be ideally done in very young infants, days old or weeks old or even a month or 2 months old, because these values are highly unreliable, and it takes up to 6 months for all the vitamin K dependent or liver related factors to mature. The platelet counts could be in normal adult range in both term as well as preterm infants, but the platelet function could be a little bit hyporeactive. Now, because of the volumes of blood required, also the platelet aggregation testing should not be done in the neonates, because it really, even for an adult to do a platelet function test, we require 10 ml of citrated blood sample to get a good amount of platelet rich plasma. Now the platelet glycoprotein expression, the surface glycoprotein expression is normal even in the neonates. So flow cytometry can be done to rule out Glanzmann's thrombasthenia or Bernard-Soulier syndrome, because you cannot do platelet function. Now bleeding time could be shorter than the adults and of older children. Now here the von Willebrand concentration, von Willebrand factor is high. There is presence of large VWF multimers and the packed cell volume is high. Now this table shows the clinical laboratory approach for the diagnosis of bleeding in newborns. Now you get reduction in factor 2, 7, 9, 10, 11, 12. So overall you get low thrombin generation. The coagulation factors are more or less normal for fibrinogen factor 5, factor 13, raised factor 8 and VWF. And the primary hemostasis, the platelet count is normal, but the platelet function could be little hypo activated. But since the factor 8 and von Willebrand factor is high, you can get little bit enhanced primary hemostasis. The plasminogen TPA alpha 2 antiplasmin, the fibrinolytic system could be lower, and you can get a hypofibrinolytic state. Of course, the natural anticoagulants, antithrombin PCPS is low, and that's why you should not be doing it for the first 6 months. Now, this is a comparison of a sick neonate versus healthy, and what could be the possible diagnosis. You get lower platelet count with a raised PT-INR APDT, it could be DIC, or low platelet count with normal PT APDT, it could be platelet consumption, or the normal platelet count with raised PT APDT, could be liver disease. Dr. Srimati is calling. I'll just pick up this call. Yeah, Srimati, I'm in the talk. Yeah. Oh, great, great. I'll call you. Yeah. So in the healthy neonates, if you get a platelet count normal with raised PT, APDT, it could be vitamin K deficiency, because both are deranged. If you get only the APDT high with both the platelet count and PT normal, it could be hemophilia. And everything normal, it could be because of trauma, and the patient is still bleeding. It could be because of trauma or any qualitative platelet defect like Glanzmann's thrombasthenia. Now, the most important part, when you are establishing your own lab, or you want to start the coagulation screening, you cannot use everything that is commercial. So you need, even we are using the homegrown normal pool plasma and the deficient plasmas for doing factor assays or using as a normal control. So for preparation of normal pool plasma, you should always take 15 to 20 healthy individuals which are blood group balanced. So as we know that O group individuals, they can have the clotting factors slightly on a lower side, whereas the other groups A and B, they can have the clotting factors on a higher side. So they should be always balanced irrespective of the sex. And this normal pool plasma has to be always calibrated against a normal control or a standard reference control. And then the values have to be recorded. Like for example, your normal pool plasma, homegrown normal pool plasma has a factor 8, suppose of 120%, and has a factor 9 of say 90%. Then if you are using that as for doing the factor assays of your patient, because the factor levels you always give in comparison with the normal. So we say 80% of the normal. We assume that as normal is 100%. But if normal is 120%, then you are talking about 80% of 120%, or you are talking about 80% of 90%. So your calibrated plasma, your normal pool plasma has to be always calibrated at least for the common factors that you're doing on a daily basis. And then you have to do a mathematical calculation. So if it is say 80% of 120%, how much of 100%? That mathematical calculation has to be done, and then the final report, the value has to be based on that. Otherwise, you will end up under-reporting or over-reporting of the factor level. So that is very important here. Now the deficient plasmas as well. For doing factor assays, you require factor 8 deficient plasma or the factor 9 deficient plasma or any other deficient plasma. So these patients, the common factors are factor 8 assay and 9 assay. So a severely deficient factor 8 patient, you can collect the plasma. You have to make sure that there is no inhibitor in it, no lupus anticoagulant in it, and the TTD status is negative, no viruses in it. So then you can store this plasma and into smaller aliquots at -80 degrees and use it as your reagent, both your NPP for your everyday control and the deficient plasmas for doing factor assays. And one rule is, once you thaw an aliquot, you should never refreeze it. You thaw an aliquot, do the assays, discard it. Now, this laboratory or this department has always been a part of the quality control programs, both of the UK NIIHS as well as the CMC Vellore conducted the EQUAS program. So we are always in consensus with all the quality standards, and that's how we make sure that our values or the assays are at par with everyone else worldwide. And these are the instruments that are used for any laboratory. You will definitely require a thermostat controlled water bath. Circulating water bath, if it is there, it's even better. Then you at least require a semi-automated coagulометр. Having a fully automated coagulометр is an advantage. Now the principle of this semi-automated coagulометр is mechanical. So here you have the steel ball, and it is electromagnetically controlled. So when there is a clot formation here, the movement of the steel ball is restricted and the time is given out as a spike. That time is measured in seconds. So this is the evolved version of the same instrument here down. This is another ACL top. This is another fully automated coagulометр. This is from Stego. This is from ACL top, and this is a flow cytometer. So basically, what you require is at least a water bath and a semi-automated coagulометр. Then we also have this instrument called the ROTEM, rotational thromboelastometry. Previously, we had the TEG, that is the thrombin generation. This is the TEG and the earlier version of thromboelastometry. This is the rotational thromboelastometry now, the current generation. This is particularly useful in a hemostatic lab if you are looking at or suspecting a fibrinolytic deficiency. because any of the assays that we are doing, where the end product is the clot formation, fibrin clot, fibrinolytic defect is not picked up there. So you do a PT, ABDT, everything, you will get everything normal. But if the clot is unstable, you will not, it will not be picked up there. So the thromboelastometry, it can show if there is any fibrinolysis or the clot formation part is normal and the clot is unstable at some point and the clot lyses. So you can pick up a fibrinolytic defect. Then we also have this thrombin generation equipment, that is endogenous thrombin potential. This is the earlier version of it. This is the fully automated. We have both of them. These are required particularly in research setting, not in a routine assay. And this is our department. She is Dr. Shetty, you all know. He is our earlier director, Dr. Ghosh. Thank you. Which are you ready?
Wait
Yeah.
one second, I'm just waiting for questions.
You have any
Ask even online if they write it in the chat.
screen sharing and stuff? Okay.
Oh, okay.
You
And I
have written in chat. You put no? Yeah.
They might have received plasma transfusion of the sample came. So how long we have to wait?
So ideally we tell at least a week, but yeah, because see, every factor has different half-lives.
So like if a patient,
Like for example, if you have to look into say ADMTS 13, ADMTS 13 has a half-life of 3 days. So depending on how much of infusion is given, now at least if you want to say see that if there is a deficiency or no deficiency. If you wait for a week's time, you can, I mean, that can, it will be like a washout period and you can still get. Now, if for example, factor 13 has a half-life of 1 month. Now, if you give plasma, and then you're suspecting factor 13 deficiency, you will not get, the baseline for a long time. So it depends actually what you're looking at. So if you want to do a factor 13 assay, or if you want to look for a 13 deficiency, then you really have to wait for a little longer time before you send it for a factor 13. Or if it's a protein that has a very short half-life, then you can wait for a shorter period.
secondly about certain which acid or silica.
Yeah.
We don't have much option because if you are using one or the other automated analyzer, particular reagents can only be utilized in those analyzers.
Yeah.
So how do you ensure that? Because usually if like I'm using system, so there it comes with allergic acid.
Yeah, allergic acid actually works very well with most of the. Yeah. So allergic acid works very well for most of the extended half-life products. Or if you have a semi-automated coagulator, there also, I mean, it's kind of an open system. There you can try using, if you want to use something else, which does not work in a closed system, then you can use a semi-automated coagulator and then do the assays there.
So, few more questions. What will be the ideal value of factor VIII in NPP?
So ideal value should be 100% of all the factors, but that's why you have to do a blood group balanced collection of NPP. So if you are more kind of, if you have more individuals with O blood group, you will end up having your factors little on the lower side. Or if you have more individuals with AB blood group, your overall factor levels will be on a higher side. So that is the reason you have to balance out the blood groups when you're collecting for NPP. Ideally, the reason behind that is you want to keep your values around 100%.
If the patient is on EHL, extended half-life factors, what activator should be used in the APDT reagent? And do you get a request form that patient is on which, okay, in our pro forma, I think, do we have a point where which EHL product is used?
Yeah, so there are very good publications which talk about or compare different reagents with different activators and patients, and and they have tested it on patients who are taking different kinds of extended half-life products. So accordingly, you can use the APDT reagent. Now, here in our setup, we work very closely with the hematology department of KEM Hospital. So we know what kind of products are given by the Department of Hematology, and accordingly, the reagents that we are using is kind of good for those factors, and we are not kind of out of sync. So you can work closely with the Department of Hematology from where you are getting the samples. Maybe you can talk to the clinicians or the hematologists there, what kind of products the patient is taking, and then you can choose the reagent that you are using. But there are very good publications which have given very beautiful comparison of the different reagents used and on the patients who have taken different kinds of extended half-life products.
I think one question is repeated. When shall we do coagulation studies if patients have received plasma or platelets?
Yes. So the half-life, it all depends on the half-life. Now the platelets, the half-life is about 8 to 10 days. Now, if you are suspecting a platelet functional defect, then or if you are even that even applies to if you have given FFP or cryo, and then it depends on what kind of factor you are suspecting, the deficiency you are suspecting. If the factor has a very long half-life, like for example, I gave the example of factor 13, which has a half-life of about 1 month, versus some other factor which may have a half-life of few hours or a few days, then you have to wait accordingly before doing the baseline assay. Or if a clinician clinician might also be interested in knowing what is the value right now, because I want to see what is the status, the hemostatic status of the patient right now when the patient is on, like I have infused, but I want to see what is the correction, whether I need to give more infusions or I can wait. So I need not necessarily always require the baseline value. I mean, the clinician may just require what is the hemostatic status at the moment. So there you can still do the assays, but then you have to mention in the report whether it is a post-transfused sample. If it's a post-transfused sample, then how many days post-transfusion the sample has come to you. All that has to come on the report so that there is no confusion later on.
Well, if a patient has to go for a surgery, the patient knows and one surgery like to go for a factor, what should be the optimum levels? Secondly, whether the number of days matters. When was the last dose taken for the factor?
Yes, definitely. It depends on the kind of surgery. Like for example, if yeah, then there is 100% correction is required there. Like for example, if a hemophiliac wants to take a vaccine, for example, then at least 10% of the factor level should be maintained. It should not be below 10%. Intramuscular injection if he has to take. Like if it's a major surgery, then there has to be 100% correction. That has to be maintained. That hemostasis has to be maintained till the patient actually heals out of that surgery. So it depends really what is the invasive procedure.
And is there any option or utility of intraoperative factor during the surgery?
Yes, during the surgery also you can in between send, like if you are infused, you can, I mean, we do get the sample to, what is the hemostatic status of the patient. But then you should have a laboratory which is on the standby, which can give you the levels immediately. Yes, so you should definitely have a laboratory which is ready to and waiting for the sample to give you the value. But then you have to absolutely have to be sure that there are no inhibitors, because if you are given 100% correction and the patient is bleeding, then I mean, you have to make sure before operating on the patient that giving 100%, whether it is going to be enough, whether the patient has inhibitors. So all that has to be ruled out before the patient is operated. Okay, so if there are no more questions, thank you very much. And I invite Dr. Rucha for the next talk.
Okay. So good morning, one and all. So today I'll be speaking on the topic of coagulation tests and the interpretation. So there is going to be an overlap, but the main aim of this talk is how do we interpret finally with the laboratory results, with the bleeding history, everything combined, how do we at the end give a diagnosis? So, one second. As it was already told, there are hereditary bleeding disorders could be classified into two types. Either you may have the coagulation disorders, which are the deficiency of different factors, or you may have the platelet function defects, which is Glanzmann's thrombocythemia, Bernard-Soulier syndrome, etc. So at our institute, till date, we have diagnosed many coagulation factor disorders along with platelet function defects. So now coming to the main aspect. If you want to give a diagnosis to the patient, laboratory is not separated from the clinical aspect. At the end, you have to combine both and then only give a diagnosis. So totally, you have four main steps to give a diagnosis for a bleeding disorder. First is a complete history. Second is a physical examination, which is done by the clinician. Then you have the complete blood count, peripheral smear, and the screening coagulation tests. So based on these three, that is a complete history, physical examination, and the screening test. Then looking at all three aspects, you go finally to the specialized factor assays or tests so that you can confirm the diagnosis. So let's cover one by one part. So coming to a complete history. In our laboratory, whenever a patient comes, we have a proforma, a routine book, which is filled for each and every patient which comes here. So this is how the proforma looks. I've divided it into three parts. It includes everything, whether the patient is born of a consanguineous marriage, the blood group, what is the current bleed at this point, what is the current medication, is he recently transfused? Then different other aspects like how many number of bleeds per month or per year, age of diagnosis or age of symptoms if he's not diagnosed, the age of which he was ever transfused because of bleeding, the family history, and the most important part is transfusion, that is current and past. This all has to be noted. Along with, we take a detailed past history, bleeding history of the patient. So you can see there are different kinds of bleeds which we have in our routine proforma. Then we select whether it's a yes or no, whether the patient has ever suffered from epistasis, ecchymosis. Going ahead, SNT stands for whether this bleed was spontaneous or traumatic. And then going ahead with the number of times the patient has bled, this particular bleed. And for this particular bleed, whether the patient ever required transfusion. So once you summarize all this and you take a family tree, that is if the patient has relatives who are also bleeding, All this needs to be taken in account of. If the patient has done a PT, APTT somewhere from outside or any test from outside which would give an indication, all the reports should be entered. And then only we collect the sample and go ahead with our testing. So this is what we have recorded and kept in our records for each and every patient which comes. So the three main questions which have to be answered in this pro forma is, does the patient have a systemic defect or is the bleeding the result of a local anatomic defect? Is the bleeding due to vascular, platelet, or coagulation defect, or some combination of these? Is the hemostatic defect inherited or acquired? So your entire bleeding history should answer these three questions, because a good history can directly make you come to know that, yes, the patient is mostly this disorder. So it is very important to ask whether the patient has, whether the bleeding has been lifelong or it is just recently which has happened. So you come to know it's acquired or congenital. The family history, and the most important is the gender of affected people. You all know that hemophilia is an X-linked genetic disorders which affects males. As soon as in that family history you come to know a female is affected, you have to suspect von Willebrand disease. So that is why gender is also very important. Now this comes to the physical examination which is done by the clinician. So there are two general patterns of bleeding seen on these patients. One could be the primarily cutaneous and mucosal, which occurs immediately after an injury or trauma. These are generally seen in platelet-related bleeding. However, you have the other kind of bleeds, which is deep tissue or joint bleed, where the bleeding is more likely a little delayed, and this is generally the coagulation defects. For example, we have patients coming directly with joint swellings. So as soon as you see these patients, you know it's a hemophilia child, or it may be factor VIII or factor IX deficiency. So looking at this, all the clinicians sense that most likely this, so do the laboratory test to assess whether the patient is hemophilia or not. So now coming to the laboratory part. So the first part is done, the history is taken. Second part, the clinician physically examines and sends the patient. Coming to the first aspect, that is the screening. What all should the initial screening include? First, you need a CBC. You need a smear. You need prothrombin time, activated partial thromboplastin time, and thrombin time. For every new patient coming with a bleed, you have to do even platelet aggregation studies. This is done with ristocetin, ADP, collagen, and arachidonic acid. Then again, the screening should have all this. If any of it, that is either PT or APT, is prolonged, do an immediate mixing with normal pool plasma. Why? Because if there is a complete correction in the immediate mix, it could give you an indication it's a factor deficiency. If there is less than 50% correction, you can think of it as an inhibitor. It could be either lupus anticoagulant or a specific factor inhibitor. So this slide shows everything that should be there done for the initial analysis first. So looking at what report you get in these tests and going back to the history, you now go ahead with special tests which have to confirm the diagnosis. So coming to the tests, this was shown, this is our table, that is, if PT or APTT or a combination of PT and APTT or all three are prolonged, which factor assay to go ahead with. This chart shows that, but now I'm going to take it one by one. So coming to a patient who has come to us who has a bleeding history, and we get PT prolonged. The APTT TT is normal. Okay. The values are such. You have a patient with PT 25.1 seconds when compared to a control, which is 12.8. So this is the screening. What is missing from this screening? As shown in the first slide, it is very important for a mix to come into place. A mix of 13.0 seconds shows that it may be a factor deficiency. So now, only PT prolonged is generally suggestive of a factor 7 deficiency. So I go ahead with my factor 7 assay. I get factor 7 reduced, that is 15%. Do I go ahead at this point and issue the report? At our laboratory, we do not stop here. We perform one more liver or vitamin K related factor. That could be factor 9. This is to assure that it is only factor 7 deficiency and it is a confirmed report and it is not related to liver or vitamin K related deficiencies. Then we issue the report. Coming to the next aspect, only APTT prolonged. So I have again a patient who is bleeding. His APTT is 66.1 seconds. The mixing is 31. Now we do the factor assays that is dependent on the prevalence. So you do a factor 8 first, then you do a 9, and then you go ahead with the factors. So I do a factor 8 levels and I get 1.8%. Should I issue the report at this point? No. At this point, I go to my screening of platelet aggregation with ristocetin and BWF antigen. Very important because every hemophilia patient should be ruled out for von Willebrand. When I see the combination of these two reports, either or can happen. I may get factor 8 reduced, ristocetin aggregation nil, and BWF antigen nil. So this patient is a von Willebrand disease and I can issue the report. Second, I can get only factor 8 reduced, which may indicate or which is hemophilia A. But again, at our laboratory in our department, when we first diagnose a patient, we do not do only one factor assay, we even do a factor 9. So the first report, the diagnosis report, which has the basal levels, should always have both 8 and 9 levels for a hemophilic child. Why is this? Over here, the immediate mixing is correcting, but many of our patients have lupus anticoagulant. And when a patient has a strong lupus anticoagulant, you get other factors also reduced. And that might be a confusing thing, and you should not issue the report at this time. And that is why we suggest do both the factors 8 and 9 before issuing a report of hemophilia A or B. So this is our approach. First time diagnosis or when the immediate mix is not correcting. We do not stop with only factor 8 levels. We go ahead with a factor 9. And if the factor 9 levels also come reduced, you do an LA. You come to know it's a strong lupus anticoagulant, so you call the child again for a repetition after 2 weeks when the LA probably has subsided. Now, going ahead with the same thing, I have APTT prolonged. Here it's interesting. This is a patient who has no bleeding, but is posted for surgery, and that is why I did a PT and APTT. I get an APTT prolonged. These are the values. That is the PT is 56.1 seconds. That's why I said when the screening should go back with your bleeding history. Okay, and the combination of both should hint you what to do next. So rather than doing a factor 8 and 9, because but obvious factor 8 and 9 patients would bleed, this should immediately strike you, let's do a factor 12 assay. Why a factor 12 assay? Because it is a rare genetic bleeding disorder where you have an APTT which is deranged, but you don't have any bleeding tendencies. Okay, apart from this, even there is something called as contact factor deficiencies, which was covered. So in contact factor deficiency also, the APTT is highly deranged, but there is not that much of a bleeding of a 120 seconds APTT. So all this should be taken in mind before giving a normal report, and one should screen this. One more case. I get an outside report of a patient that is APTT is 48 seconds. Again, this patient has no bleeding. Now, this is an outside report. Okay, so they've not done the immediate mix. It comes to us, we tell them, we will do the screening. Our report is PT, APTT, and TT is all normal. So what is it? That lab has gone wrong? Absolutely not. The laboratory has not gone wrong. What happens is, for bleeding disorders, it is actually useful to use an APTT with high phospholipid, which is not done in every pathology lab. They generally use an LA sensitive. So we do not issue a report over here. We repeat the test with APTT with low phospholipid. As Bipin said, you should have all the APTTs with high phospholipid, low phospholipid. By doing the APTT with low phospholipid, we also get a APTT similar to that laboratory. We do a DRVVT LA and prove that the patient is not a bleeding disorder. It's just LA, and that is why the APTT is prolonged. Coming to the combination of PT and APTT deranged, so it attacks the, meaning we have to go ahead with the common pathway, that is 5, 2, 10, or a combined deficiency. Again, over here, by rule in our department, we do not stop with one factor, do 2 factors at the first time of diagnosis to exclude any liver or vitamin K related issues. Coming to all 3, PT, APTT, and TT being deranged. Over here, you need to look at the fibrinogen. It is very helpful if you can do a reptilase time along with thrombin time. It helps you classify whether the patient is an afibrinogenemia hypofibrinogenemia or the dyspep. So we do fibrinogen levels by a modified floss assay. Along with that, you can even do an ELISA. So it's only in dyspep where in ELISA you'll get the normal antigen levels, but the functional will be nil. So this indicates, but for every patient which comes with PT, APDT, TT deranged and a fibrinogen also less, you call the patient for a repeat sample and repeat it again before giving a diagnosis. Why? What is one more reason why this all could come deranged and fib? DIC, yes, DIC sepsis all is written. One more reason, a very simple, it's the sample. The collection is wrong, the processing is wrong. Okay, the most annoying thing is you have bulbs with the marks labeled, but it's either collected above the mark or the below the mark. So it is very important to know that coagulation factors, the ratio of anticoagulant blood is very important to get precise values. So this could be one reason why everything comes deranged. So a fibrinogen or any of it should be repeated for that patient before issuing the report. When 2 times you get the same results, you know that yes, it is a case of fibrinogenemia, AFib hypo. Now coming to the next aspect, that is my PT, APDT, TT all is normal. Oops, sorry. And the patient is still bleeding. So now I look ahead with my other screening aspects that was put on the first slide, that is platelet aggregation and a factor 13 assay. But am I missing something at this point before going and checking these 2 assays? Yes, mild hemophilia. So many a times mild hemophilic patients, they bleed when they are pretty, like at 35 or 40 years of age, when they have a dental surgery or something like that. Okay, and the problem over here is APDT comes in the normal range, that is 30 to 34 seconds. So you may actually do a PT, APDT, TT, give it as normal, do an aggregation which is normal and factor 13 which is normal and diagnose the patient as a normal study. No, that is why at our department, for every patient who has a bleeding history, which suggests that they could be a mild hemophilic, do a factor 8 and 9 even if the APDT is normal. Okay, this is to rule out any mild hemophilia. So now going ahead with the aggregation results. So as I said, my screening is normal, PT, APDT, TT, the patient is bleeding. I get a graph like this in aggregation, ADP nil, Risto normal or reduced, and collagen nil. What can I suspect looking at the bleeding history, etc.? Looking at this picture, yes, I can think it is Glanzmann's thrombocythemia. At the same time, one should all know that platelet aggregation is affected by many drugs and medications and even certain foods. Thus, this aggregation should either be repeated or you have to do confirmatory tests by flow cytometry. Either or. And not only that, the sample processing, very important. Once you remove the platelet-rich plasma, you have to process aggregation within 30 minutes, maximum 1 hour of separating it. It cannot be lying in the laboratory for 1-2 hours and then you will get everything nil and reduced only. So keeping into mind, this has to be repeated or flow cytometry would give the confirmatory test wherein the GP2B or 3A or the combination of 2B, 3A is nil. Next patient. So again, I get PT, APDT, TT normal and I have an ADP which is normal, Risto reduced, collagen normal. I check the factor 8 is normal. So I'm ruling out von Willebrand disease. I go back to the history. When I see the history and CBC, I find that the patient has giant platelets. Looking at these 2, that is why I said the combination of the bleeding history, CBC and the screening test, I can suspect that the patient is Bernard's syndrome. Again, but this cannot be given until you do a confirmatory test where you get GP9 and 1B nil. Okay, always remember once the sample is collected and centrifuged, within 30 minutes, the platelet-rich plasma needs to be processed for aggregation. Otherwise, you will get everything reduced or nil. Coming to the factor 13 tests. So when everything comes normal and still the patient is bleeding, you have to finish it off by doing a factor 13 assay. All of us know that there is a urea clot lysis simple test, which is an overnight test, but it diagnoses only severe factor 13 deficiency. Recently, we had a small study in which we found 3 patients who had a history, okay, and we had done the ELISA for factor 13 levels. And we found reduced, not nil, but reduced factor 13 levels. So we called the patients back and we did the urea clot lysis, and still the clot was stable. Okay, though it was reduced in the ELISA. So what we did is we did the acetic acid clot lysis method. And what we found is in acetic acid clot lysis, these patients, the clot lyses. Why? Because it is known that this method detects the mild and moderate kinds. So we suggest that both these assays should be done to final diagnose whether it's factor 13 deficiency or not. And the most important part for factor 13 assay is the half-life of factor 13 is more than the other factors. It is 5 to 7 days. So if a patient is transfused even a few days back and has a remainder, and you do only the urea clot assay, you will get clot stable. So for factor 13, repeat the factor 13 when the patient is not transfused for at least 10 to 15 days. So I'm now going to summarize how we go ahead and how we interpret and give a diagnosis at our laboratory. As I said, the first aspect is patients with bleeding history. You have to take and fill a good pro forma for this. You note the type of bleed, the family history, the males and females affected, and whether it is recent bleed or a lifelong bleed. You check the platelet count, the CBC, the smear, and the screening coagulation test, along with the platelet aggregation test. And looking at all three combined, you go ahead with further tests, that is either factor assays or von Willebrand, depending on what you get. If everything is normal, then you end it with doing a factor 13 test to diagnose factor 13. And when each PT comes prolonged or an APTT comes prolonged, you have to do the suggested factors. As I said, do not stop with one factor when you're giving a first diagnosis for a patient. If the patient has a bleeding history, like a dental surgery bleed when he is like 35 or 40, which indicates that there might be a mild factor deficiency, and even if the APTT is normal, do a factor 8 and 9 assay. Okay. And as I said, first time patient, do more than one factor assays. The most important points for interpreting is that if more than one factor assays is reduced, or you get weird results, do not keep repeating the test. Rather, collect a fresh sample and do it on a fresh sample. Okay, the sample collection could have gone wrong or anything could have gone wrong. So repeat it with a new sample. Aggregation studies are affected by medications, by drugs, by food. So this all has to be taken into account in that history itself. And then either it's repeated or you do the confirmatory test, whichever is possible by the laboratory. We suggest doing both urea clot lysis and acetic acid method for factor 13 deficiency. Remember, for every hemophilia A patient or whenever you get factor 8 reduced, you have to rule out von Willebrand disease. And for the basal factor levels, now a patient, each and every patient needs a basal factor levels as the main report. The patient should be called when the patient is not transfused for 5 to 7 days. Always, always, always correlate the test results with the clinical bleeding history and only then give the diagnosis. Thank you.
I have a question.
So what we recommend is when the patient is coming for platelet aggregation, we tell them to have a very light, like only milk and Mari biscuit, to be very honest. A strong ginger tea or even onions and etc. A strong heavy breakfast could even affect it. So every time a patient comes, don't come fasting, but have the lightest like Mari biscuit and milk and come, so that nothing, your aggregation results come at. By how much should the PT and APTT correct to call it as correction on mixing study? So to be honest, a correction on mixing studies, it's the other way around. So if you get a less than 50 correction, you can think of it as being inhibitor or LA. Till then, depending on the APTT. So for a hemophilic patient, if an APTT is 100 seconds, you're not going to get complete correction. You will get it as 35 or 37. So you have to look at that and judge whether it is correcting or not. So 50% and low would suggest an LA or an inhibitor. How many seconds prolongation compared to control is considered significant for both PT and APTT tests? So now if the range is 12 to, now for PT is 12 to 15 seconds, we consider for both PT and APTT a 3 seconds more than this value as an increased value. But as I said, for APTT also, if it comes in the normal range, we do a factor 8 and 9. I can't see any other questions apart from these two.
Any questions for the floor?
Importance of two indication of complete time analysis. Because anyhow, PT, APTT is delayed. Would be directly go with 50. Thus, complete time about any has to be performed.
Yes, we do it every time a PT and APTT
It
is
not a
deranged.
mandatory investigation. But for example, if you want, say, if the patient is on heparin or not, so a thrombin time versus a reptilase, there it can help you distinguish whether this prolongation is because of any heparin effect or if there is. So it is not a mandatory investigation as per this thing norm.
The approach of bleeding disorder.
Yes. So yes, so it is not one of the like PT and APTT is not a mandatory, but you can do it as an additional information to particularly to see if there is any heparin in the sample. Yeah. But it will be an added advantage if you have thrombin time in along with reptilase, because it can distinguish
Type of
Fibrinogen. AFib, hypo, and this.
So if thrombin time is deranged, you can get a still normal reptilase time. So if there is a heparin contamination.
Why I'm asking this question is that till date in last 6 years, we have received only hardly 2 or 3 requisitions for thrombin time. Okay. And our reagents got expired, and even the clinicians said, why you want to perform a thrombin time?
It is like a sort of a control.
Heparin contamination or information from the heparin. For monitoring also, they have never asked for the.
See, if you get PT and APTT both unclottable,
Then we directly go with the.
you can go directly for fibrinogen, or if you don't want to go for fibrinogen directly, or before going to fibrinogen, if you want to see if there is any, is it because of a heparin contamination, you can do a thrombin time and a reptilase, like if you have it. Or that's why it is not a mandatory investigation. Since you have other investigations to cover for it, if you are going directly for fibrinogen, then you don't need it.
Second question is that how important, like you mentioned, the protocol which you are following in your department is that for every suspected bleeding disorder, you are going for aggregation studies.
Yes.
Be it coagulation rate, if at all if the patient is having clinically presenting with large bleeds and all, then also you.
No, so what we do is when the sample comes, we process it such that we keep the PRP aside. Okay, so now if only PT is deranged, you will look at only the factor 7 and go ahead. But so that the patient sample is not collected again and again, we do keep the PRP aside, and if required, we do the aggregation on that.
If required. Not
Yes.
with all the cases of bleeding.
That is the first time presentation.
Presentation.
Spoke about. Like if it's the first time diagnosis that you're doing.
Yes.
Even for the first
Yeah,
time.
first time diagnosis, it's better to have a comprehensive hemostatic picture. Then on when the patient goes anywhere to any hematologist, he will have a complete holistic picture of everything. Like as a first time diagnosis, you have done everything.
So, like you mentioned that there are many pre-analytical variables, particularly.
Yes, yes.
So that might also confuse the final interpretation, like medications, drugs which you are talking.
But that's from the lab point. So you have to mention that. You have to repeat platelet aggregation. If it comes that way and you know the patient is on medication, don't perform. If you know, like if the patient is on Trenexa or something like that, we do not perform because we know that affects the platelet aggregation. So when you know it's a clear picture and still it remains, you call the patient again for this thing, because unclassified platelet aggregation is seen only by doing this. Where everything else comes normal, but on repetition of 3 times, we've seen the aggregation abnormal.
So will you, for suppose if a setup does not have this aggregation, will you call that workup for the bleeding disorder? So you still complete workup or or
Not if von Willebrand antigen is done.
not if one?
Platelet function is a screening test at that level. So it is not diagnostic. So even if you get something wrong with platelet function, you have to either confirm it by flow cytometry or by doing von Willebrand antigen.
So if you're doing that in a suspected case, that's fine.
One more question from your previous talk. So you spoke about Rotem and TEC. So what's the difference between the two methodologies or the principles? And do we get different information from both of these tests? Or
Yes.
they both
So
provide the
take
same?
the thromboelastometry. The principle more or less is similar. Now, take earlier they used to use only single concentration, single reagent and tissue factor. But now with rotational thromboelastometry for specific pathways, they have specific stimulators given in different concentrations. So you can either, for the extrinsic pathway, you have a different reagent. For probing the intrinsic pathway, you have a different reagent. For the fibrinolytic pathway, you have a different reagent. So it is more made little more specific to specific pathways. So it is more sensitive to different kinds of pathways. So that's why when there is a fibrinolytic disorder, then a Rotem is little more sensitive than a TEC would have been.
And does it give us any additional information, particularly if we are going with the kind of factor deficiency?
Yes, like initially it gives like the initial clot formation is deranged. Like it doesn't tell you what factor deficiency, but the initial clot formation, like for example in Rotem, if you are doing like XTEM, if you are putting that probes the extrinsic pathway. So if obviously there is a factor 7 deficiency, it will give you a prolonged CT value before your clot formation happens. So
I am asking, like if we are performing factor,
It's not
no,
required.
it is not required. See, Rotem is not a
Research.
routine investigation.
emergency
It gives a kind of a holistic picture. It is used particularly in patients where you have done all the assays, still you don't get the diagnosis and the patient is clinically bleeding. You don't know what to do, where to look. So there it kind of gives a holistic picture, because when you do the screening coagulation like PT, APDT, TT, fibrinogen individually, your assay stops the moment your clot is formed. So you're not able to probe it further. The endpoint is clot formation. So particularly in cases where you are suspecting a fibrinolytic defect, because the fibrin, like for example, alpha 2 antiplasmin, if you want to do it, so these are single cases that you get. You may not get another case in next few years. So if you have to have those assays, like if you want to do the alpha 2 antiplasmin ELISA, you may have to spend a lot to get the ELISA just for one sample, which may not be feasible. And you are like kind of firing in the dark. You don't even know whether it's that deficiency. So it is like a screening, like you want to see whether there is a genuine fibrinolytic defect or not. So once you get a defect there, then you can probe into the fibrinolytic pathway and rule out one by one if you are keen on doing that.
And in absence of like aggregation studies, like for by flow cytometry or
GT and BSS.
for the secretion. So will that suffice for the aggregation?
Secretion defect you can look into by doing aggregation itself. I have a study going on, and we have got some beautiful results. Also, we'll talk about it during the lab sessions. So you can do it by UV aggregation. Yes. So if it's a secretion defect, like ATP release, so you get the fluorescence. It comes from it is proportionate to the ATP that is released. Yes, luciferin. So that assay you can still do on aggregation.
But on flow we can't identify the secretion. So we are not targeting any.
Yes, yes. But on aggregation you can. But and the end result of it is say activation. So if you are suspecting a particular pathway defect which leads to activation via a certain pathway, then you can still look for the activation markers on flow cytometry. Like for example, if something is affecting your platelet activation, you can directly look for activation markers. CD62P you can look for whether the activation is happening or not happening.
Okay. Thank you, one and all. And tomorrow we have a very interesting and exciting lecture by Dr. Jasmeena, ma'am, who is going to speak on von Willebrand disease, how to diagnose them. We know that there are many types in that and subtypes, and the diagnosis may be confusing. So that is there tomorrow. So I hope to see all the online participants tomorrow sharp at 10 a.m. tomorrow. Thank you.